Ms. Thompson.
Good afternoon, Doctor. Before lunch, we were looking at your terms of appointment, and I wonder if we can perhaps put those back on the screen. They were in paragraph 14 of your inquiry statement. Thank you. And we were looking at the third term of appointment, quality assurance of the training of medical skills, including delivery materials and practice. And you explained to us that you look both at officer safety techniques. You mentioned the risk of PAVA injury, batons, handcuffs and so on, and first aid techniques such as using face masks, defibrillators, tourniquets and packing wounds. Before we go any further, there's one matter I'd like to clarify with you, please. There's evidence before the chair that there were two different types of first aid training within the police, or there are still two different types of first aid training within the police. There's the first aid at work 3-day course, and there's evidence that the syllabus for that is set by the Health and Safety Executive. And there's a shorter course. It used to be called SPELLS. It's now called Operational First Aid, and that's the course that all police officers undergo. Only a smaller number of officers, including those who go on to deliver officer safety training, required to take the first aid at work course. And I wonder if you can help us to understand whether your involvement in first aid techniques relates to the first aid at work course or the operational first aid course, or potentially both.
I would say it's potentially both.
Thank you. Returning to this term of appointment, the quality assurance of the training of medical skills, including delivery, materials and practice. There are 3 parts to that term of appointment: delivery, materials and practice, and I'd like to look at each of those in turn. What is asked of you with a view to you providing quality assurance of the delivery of medical skills in the context of officer training?
So I'm asked to look at the syllabus that's been provided and look at the training material that has been developed by Police Scotland and review those for being up to date with medical practice.
Okay, so you review the syllabus and training materials and consider whether they're up to date and in keeping with medical practice.
Yeah.
Now, if we look again at the term of reference, it's quality assurance of the training of medical skills, including delivery, materials and practice. So I can see how the review of the syllabus and the training materials would provide quality assurance of the materials themselves. But I'm wondering what has been asked of you with a view to ensuring quality assurance of the actual delivery of the training that officers within Police Scotland receive.
I would say I've not really been involved in that.
Can we go back to paragraph 11 of your statement for a moment, please? I'm asked if I only advise on the written content or whether I'm asked for advice on the police training and practice in scenario training or practical training for officers. I've been doing quite a bit of scenario training recently with the firearms trainers and the public order trainers, not so much with the first aid trainers. I've been assisting with the delivery and the training techniques that have been used by firearms and counter-terrorism. And at paragraph 12, I have not been hugely involved in the standard probationer training or recertification training for ordinary constables who may be involved in restraint or dealing with knife incidents. I'm asked to look at a broad overview to see if there's anything glaringly obvious that would be considered a lack of safety, but not a huge amount. They seem to run their own process. I'm not involved in lesson plans. If anything new comes in, they will approach me and discuss anything with me over the phone or by email. For example, if they're talking about applying assisted respiration to a casualty, the face mask and how you use it, how it can be used, how it can go wrong. Areas like handcuff injuries as well. These are all standard injuries and techniques that are taught currently in most police training courses. So you explain in your statement, Doctor, that you've been involved in training with firearms and public order trainers, but not so much with first aid, and you haven't been hugely involved in probationer or refresher operational safety training. Have you had any involvement at all in the practical delivery of officer safety training?
No.
Have you ever been asked to sit in on the training that probationers receive?
No.
Do you think it would help you in fulfilling your responsibility for the quality assurance of the delivery of training if you had the opportunity to watch that training be delivered and provide feedback?
Yes, I believe it would.
And how would that help you?
So we would look at the delivery. We're looking at the delivery, see what information has been imparted. If they're using PowerPoint, to make sure the slides aren't too busy and that they are easily legible to people in the classroom. Also as well, looking at the trainers and see that their techniques are up to date.
You say in your statement that you have been involved in scenario-based training for firearms and public order trainers. What has your involvement been in their training?
So they have a scenario where it could be a man with a knife or a man with a gun, and then they have someone injured within the scenario, and they have to utilise their skills and techniques to usually address catastrophic bleeding.
When you you say you were involved in this training, what was your involvement? Were you an observer or were you actively involved in the training?
I was an observer, and I was taking notes to see if they were following guidelines, such as addressing catastrophic hemorrhage first, above airway breathing circulation, and making sure that they were putting the tourniquets on correctly. And they knew about packing wounds to stop bleeding.
Did you give feedback based on your observations?
Yes.
Did you find that to be a helpful process?
Yes.
And to your knowledge, did the police find that to be helpful?
Yes, I think they did, yeah.
You also say in your statement that you're not involved in lesson plans for operational safety training. Again, do you think it would be helpful for you if you could be involved in lesson plans, if you had that opportunity?
You've had the opportunity to look at the development of the plan, yes.
There's evidence before the chair that so far as operational safety is concerned, there's been a move in recent years towards scenario-based training. And I wonder whether you would find it helpful if you were involved in devising scenarios for those training programmes.
Yes, I think it would be beneficial for me and for the police.
What do you think that you could bring to the discussion?
Direct experience from managing people with catastrophic injuries, complications that can arise, and generally provide feedback.
And if we move away for a moment from the more first aid skills and focus on the delivery of operational safety skills, which might have medical implications, such as the cuffs, the batons, leg restraints, and so on. Again, would you find it helpful to be involved in devising scenario-based training for the police?
Yes, I would.
For the same reasons?
Yes.
Okay. Would you find it helpful to watch scenario-based training in progress?
Yes, I found that, especially with the firearms, because that was a new concept to me in dealing with individuals that had been shot, and the scene safety and equipment safety that's involved.
So you clearly found it helpful from a first aid point of view,
Mhm.
and I'm wondering if it might be just as helpful for you from the point of view of quality assuring the officer safety techniques that are used that have a medical implications.
Yes, yeah.
And would you find the opportunity to give feedback after viewing that training helpful?
Yeah. Yes.
Do you think it would assist you to undergo the training that officer safety trainers themselves undergo?
I believe it would, yes, because it would give me the opportunity to, for example, have the handcuffs on, and realise the limitations that has on when you're dealing with a person, and also looking at the effects of PAVA spray as well on individuals.
Is there anything else that you can think of that might assist you in providing quality assurance of the way that training on medical skills is delivered to police officers?
Just as we've said, to see the lesson planning and also be in the room when it's being delivered.
If we can return to paragraph 14 and look again at the terms of appointment, please. We're still on the third one, quality assurance of the training of medical skills, including delivery, which we've spoken about, materials and practice. Let's talk about materials now. And if we can perhaps begin by going up to paragraph 8 of your statement. You've explained already, Doctor, that you will be provided with material for you to review. At paragraph 8, you're asked, I'm asked how the process of providing input to the OST manual worked when I was first appointed as the lead advisor in 2017. I had the first meeting with a multitude of different people, police, occupational health, and a couple of other specialties as well. We were all involved in Police Scotland as an organisation. We discussed matters at a meeting and then would go away, and it would be my job to look through materials that they referred to me. I would read those documents and provide comment and approval or recommendations for change. So was this a meeting that you went to following your formal appointment in 2017?
Yes, it was.
And you described meeting with police, occupational health and others. Did this group have a name?
It was just called the Clinical Governance Group.
Police Scotland refer in a position statement to the Clinical Governance Advisory Group. Would that be the same thing?
Same thing, yes.
So that was the first meeting of that group that you attended. Have there been others since?
Yes, usually on a quarterly basis.
When was the last meeting?
That was probably 2 quarters ago. One's been cancelled. Well, the latest one was cancelled.
There's a reference in your statement, we don't need to go to it, but it's at paragraph 126, that the group stopped meeting because of COVID.
Physically. We were using Teams instead.
Oh, I see. So the meetings carried on,
Yes.
just remotely. Okay. So how many meetings have you been to since 2017? Have you been to them all?
I've attended all of them apart from one.
What is the group's terms of reference?
I don't have them to hand. I'd need to refer to them myself.
That's all right. Are you able to give us an indication of the sorts of issues that are discussed at these meetings?
So it's looking at whether new pieces of equipment that's come onto the market could be used. The latest thing is regarding do not resuscitate orders and what to do if someone's coming into custody with a do not resuscitate order in place. Or if the police go through the community, and what do they do if a DNAR form is there? Do they obey that, or do they start CPR on their own?
Are you asked to give advice at these meetings?
Yes. Yeah.
Are you asked on the spot, or are you sent materials to consider in advance?
It's on the spot.
And how do you provide advice? Is it just in the context of that discussion?
It depends on what the advice is. If it's something simple like the carriage of oxygen, that's not too bad. But something like a DNA, CPR, and the legislation around that, and whether police are instructed to follow it, that would require me to go away and read up about it.
And then how would you provide your advice?
Via email to the group.
You mentioned there being the presence of other parties on the group, including occupational health.
Yes.
Okay. Who's the representative from occupational health?
It's there's a female doctor, and her name escapes me, and there are 2 occupational health staff as well.
Are there any parties represented on the group who are external to Police Scotland, aside from yourself?
No. Oh, sorry, tell a lie. There's a paramedic. It's a consultant paramedic.
So would they be representing the Scottish Ambulance Service?
Yes.
Given that you sit on the same group as the Scottish Ambulance Service, has the subject of conveying persons suffering from ABD to hospital ever been discussed at these meetings?
It hasn't, no.
Beyond attending these meetings, what arrangements are in place for you to review materials and provide advice on the content of materials?
It would be up to me to contact the relevant sort of single person of contact in the departments, such as firearms, public order, and there was the naloxone group as well.
Okay. So would they provide you with materials to look at, and then you would respond with your comment?
Yes.
On the materials? You say at paragraph 8, we would discuss matters at a meeting and then go away, and it'd be my job to look through materials that they referred me to. I would read those documents, provide comment and approval or recommendations for change. That's something that you would follow up by email.
Yes. And
you say that the request to read material could come from firearms, it could come from the naloxone group. And we know too, through your work with Inspector Young, that you've also been asked to review operational safety training materials.
Yes.
Now, in paragraph 81 of your statement, we don't need to go to it, but when you gave your statement to a member of the inquiry team, you said that you had at home a 2017 version of the operational safety training manual.
Yes.
And you also said that it was the most up-to-date version that you had until shortly before you were interviewed. I think you were provided with the 2022 version just in advance of your interview. So I'm keen to understand whether you had seen the 2022 manual before you were interviewed by the inquiry team.
No, I haven't.
And have you been asked to carry out a review of the operational safety training manual since the review that you carried out in 2016?
No, I haven't.
You mentioned that there's an occupational health doctor sits in the clinical governance group. Are there any other doctors?
No, I'm the only doctor.
You're the only doctor. Do you think there would be any benefit in having input from other branches of the medical profession?
Yes, I think it would be helpful, yeah. Depending on their background and what their specialism is.
What specialisms do you feel might bring value to the work of the group?
So, a mental health specialist or psychiatrist.
Anyone else?
I can't quite think at the moment, sorry. I can't think of right off the top of my head. I know I'm even another emergency medicine doctor, so it's not just me on my own.
And what would be the advantage of having a second emergency medicine doctor?
It just acts as a checks and balances approach.
Do you know whether there is an equivalent group in England and Wales?
I know that every force in England and Wales have been advised to have a clinical advisory group, clinical governance group.
And is there any liaison between the Clinical Governance Advisory Group set up by Police Scotland and equivalent groups in England and Wales, to your knowledge?
There's been, within the last 6 months, a generation of a meeting of people from the clinical governance groups in England and Wales and Scotland as well.
You say that's been within the last 6 months.
Mm-hmm.
Before that, were there any such meetings?
No.
And was there any liaison with your counterparts south of the border, so far as you know, if we go further back than 6 months?
No, I wasn't.
Do you think there would be a benefit to the Police Scotland Clinical Governance Advisory Group in drawing on the experience and expertise of colleagues south of the border?
Yes, I think there would, yeah.
Can we look at paragraph 126 of your statement, please? I have been asked to explain how I normally work with Police Scotland in terms of providing advice on the content of manuals and other training materials. It is mainly done by email correspondence. The modules are emailed to me. I look over them to see if there's anything that needs to be changed from a first aid point of view and submit them back. I sit on a clinical governance group. It stopped because of COVID, but I think it meets quarterly. There's a vast array of representation around the table in occupational health, training, Police Federation, normal policing, and ACC Williams, who chairs the group. We discuss things there. Sometimes Police Scotland have done a piece of work and then think they need the clinical governance team to look over it. It might not have any input of clinical governance until the very end of the project. That probably isn't the best if you need to make changes. I'm interested in what you say at the very end of that paragraph, that the group might not have any input until the very end of a project, and that probably isn't the best if you need to make changes. Can you expand on that and help us to understand the sort of situation that you had in mind here?
If, for example, they were going to introduce pulse oximeters to measure oxygen levels in the blood, then usually what happens is an officer does a briefing for it, looks into the costings of it, and then it would be passed to me after all that's done to comment on it and see what I think, or what's my opinion of the equipment. When really at the start I could be advising them what type of equipment is best suited for themselves, you know, from a costing point of view, and also from a efficacy point of view as well.
So do you feel there would be a benefit to the clinical governance group and to Police Scotland perhaps as a whole if the clinical advisory input was sought at an earlier stage in the process? Can we look at paragraph 10, please? I'm not presented with the materials yearly and asked to review them. It's usually up to me to see if anything is new or has been introduced through developments in medical understanding that could be considered for first aid purposes in Police Scotland. They may come to me with requests, but it's my responsibility to say if there's anything major that requires change. So you say it's your responsibility to alert your colleagues in Police Scotland if there's anything major that requires change. In practice, how do you fulfil that responsibility?
Again, through email to known individuals in the groups.
And do you think it would assist you in fulfilling that responsibility if you were asked to carry out a periodic review of materials, and I have in mind in particular here the operational safety training materials, perhaps on an annual basis or something of that sort?
I think that would be helpful, yes.
We heard evidence from Inspector Young just last week to the effect that it's his opinion that there would be merit in having a wholesale review on an annual basis. Would you agree with that?
I would, yes.
So returning to paragraph 14, please, and to the terms of Dr Stevenson's appointment. We were looking at the third, quality assurance of the training of medical skills, including delivery, which we've discussed, materials, which we've discussed, and practice. What are you asked to do to provide quality assurance of the practice of medical skills by serving police officers?
So I've been watching them delivering CPR, looking at the physical aspects of the procedure, applying a defibrillator, or utilising airways to keep someone's mouth open, and recent introduction of the eye gel to public order medics.
So that all relates to first aid. I'm wondering whether you have been asked to provide quality assurance of the practice of medical skills by officers in the context of operational safety training, so the restraints, handcuffs, things of that sort.
No, I haven't.
Can you think how you might go about that task?
Yeah, it would be easy enough for me to do. We'll just write to or email the individuals that are responsible for it and ask them to, if I could come along and observe them.
But that's not something that so far you've been asked to do by
No.
Police Scotland. Would you find that helpful?
Yes,
Do you think it would help you to fulfil this term of reference?
I think so, yes.
Let's move on. The next term of appointment is review significant incidents to identify any required changes in practice, training or equipment. What have you been asked to do with a view to fulfilling this term of reference?
I've not been asked to do anything for that particular term of reference.
The next term of appointment is to review any complaints received in relation to medical care delivered by police officers. And again, what have you been asked to do to fulfil that term of reference?
I've not been asked to do anything.
Moving through the list, provide a single point of contact for medical equipment evaluation and purchase at the first instance. And I think you explain in your statement at paragraph 15, if we scroll down just a little, that you do that. You provide a single point of contact for medical equipment evaluation and purchase, such as tourniquets, oxygen monitors, oxygen cylinders, who can carry them, what the risks are. And you reference again the naloxone training that you've told us about in your evidence.
Yes.
And scrolling back up, thank you, that's perfect. Final term of appointment is to monitor the use of medical skills by police staff. What do you understand staff to mean in the context of this term of appointment?
This would be police, this would be employees of Police Scotland, but not police officers.
And what have you been asked to do to fulfil this term of reference?
I haven't been asked to do anything.
Doctor, I'd like to move on to the third and final chapter of your evidence now, which will require us to look at the officer or operational safety training materials from 2015 and those dated 2022. And I would like to go through these with you with a particular focus on the training delivered in relation to two subjects, firstly positional asphyxia and secondly ABD. So I'd like to look at positional asphyxia first. We'll look at the 2015 materials, then the current materials, and then we'll carry out the same exercise for materials relating to ABD. So let's begin with what was the training manual in place at the time, the Officer Safety Training Manual. It's PS 10938. And if we could start with the first page of that manual, please. We'll see it's copyright 2013, Police Scotland, and in the bar at the right we can see that it's, I think it says student training manual. It does indeed, thank you. We heard evidence from Inspector Young just last week that this was the central reference point for probationer training and should also have been used for refresher training after September of 2013. Can we move forward to page 29, please? I should say, Doctor, that I appreciate that in your role as Clinical Governance Advisor to Police Scotland, you will not have been asked to look at the materials that were in place in 2015. However, the inquiry has an interest in the materials that were in place at that point in time. So, medical conditions and considerations, and if we scroll down a little, we see positional asphyxia, and there's a definition offered. Positional asphyxia, restraint-related asphyxia, can occur when a subject is placed in a position which interferes with the ability to breathe. Death can occur rapidly, and it may be the case that a police officer can be found liable. Is there anything in that paragraph that you would take issue with, Doctor?
No, I think that's accurate.
Okay. There then follow a list of risk factors which contribute to the condition. Subject's body position results in partial or complete airway obstruction, alcohol or drug intoxication, inability to escape position, the subject is prone, obesity, age, stress, respiratory, muscle fatigue related to prior violent muscular activity such as fighting with police officers. Do you wish to make any comment on that list of risk factors?
No, I would say that's pretty inclusive. There are some extra causes of asphyxia, such as crush asphyxia, where pressure on the outside of the chest is being applied. For example, people that have been in a landfill, a landslide, or in the Hillsborough disaster, where people were crushed together that way.
Can we look at the first of the risk factors? Subject's body position results in partial or complete airway constriction. Is there anything that you might wish to say about that?
This is a risk factor that's applicable to police officers when dealing with individuals. So, for example, in the back of a cell van.
At paragraph 38 of your statement, and what I'll do is I'll read this to you so that we don't have to jump between documents. We'll just leave the risk factors on the screen. I'll read this out, Doctor. Of course, you have a hard copy in your folder that you can refer to at any time. But at paragraph 38, you say that the reference to airway constriction is not the most user-friendly wording. It's also not wholly correct, in that it might not be airway obstruction, it might just be chest impingement, and they can breathe to an extent, but their airways are open. Can you expand on that at all? Can you help us to understand the difference between an airway constriction and a chest impingement?
So airway relates to the lips, to the back of the mouth, the nose, the throat, and the voice box. And that would be classed as, so compression onto those areas would be classed as being airway constriction. For chest constriction, it will be applied to the entire area around the chest, front or back, and it may be partial or it may be complete.
So in your statement, when you say it's not wholly correct, it might not be an airway obstruction that is the risk factor, it might just be chest impingement.
Yes.
So the airway is open, but there is pressure on the chest.
Yes.
But on this list of risk factors, we only see reference to airway obstruction, or constriction rather. Doctor, we have heard evidence from Inspector Young, and the Chair has before him a number of statements from officer safety trainers to the effect that the training that was delivered was perhaps wider or broader than what we see set out on paper here. And we have heard evidence that officers are trained that restraint is a risk factor for positional asphyxia. But I think if we look down this list, we don't see restraint referred to as a risk factor.
No.
We've heard evidence that officers are trained that the application of weight or force to the upper body is a risk factor. But again, that doesn't seem to be listed in the risk factors in the manual.
No.
And similarly, we have heard evidence that officers are trained that the longer that a person is in a position that restricts their breathing, the greater the risk.
Yes.
But there's no reference to that in the list of risk factors.
No.
Okay. Can we move on to the signs and symptoms, please? I think it might be it's the same page, but maybe the right-hand column. Thank you. Officers should recognise the following symptoms and be prepared to administer emergency first aid. Body position restricted to prone, face down. Cyanosis, bluish discoloration of the extremities. Gurgling, gasping sounds. An active subject suddenly changes to passive or loud and violent to quiet and tranquil. Panic, verbalising they cannot breathe. Would you wish to offer any comment on the signs and symptoms that are listed there?
Just that cyanosis is a very difficult medical sign to recognise, even in hospital environments. And it's usually at the very, very end of the restriction cycle. And once cyanosis is developed, then the person is at great risk of going into cardiac arrest.
So it's a late sign.
Very late sign, yes.
Can you explain what cyanosis is? The list says bluish discoloration of the extremities. What would cause it?
So it's the oxygen is carried around the blood on hemoglobin, and cyanosis is where you have a reduced amount of oxygen bound to that hemoglobin.
You say that cyanosis is difficult to identify even to the trained medical eye.
Yes.
Is cyanosis easier or harder to identify in a person of colour?
It's harder to identify.
Can we move down the page, please? There's a description of the physiology here. Thank you. When a person has been involved in a physical and violent struggle, the exertion involved causes the muscles to use oxygen at an increased rate. The process can cause oxygen debt in the muscles, and the physiological response to that is accelerated breathing. Would you agree with that statement, Doctor?
Yes.
When a subject is restrained, ventilation, the process of getting air into and out of the lungs, can become more difficult due to the internal organs exerting pressure on the diaphragm. This is particularly evident when a subject is placed in the prone position or pressed against a surface. Again, would you have any comment to make in relation to that statement?
No, I would agree with that.
I wonder if I can take you to another paragraph of your statement, and again we can simply leave this on the screen and I'll read it to you, but there's a hard copy in front of you if you'd find it helpful to look at that, Doctor, and it's paragraph 44. I'm asked whether being placed in the prone position in and of itself would make it more difficult to breathe. It would, even without pressure being applied to the body. The vast majority of respiratory function comes from your diaphragm moving up and down. The prone position restricts that, so you can't use your diaphragm as much as you normally would. Then you'll start to use the other muscles as accessory respiration, but they aren't as effective as diaphragmatic breathing. It will be a long process to become unwell lying prone, but that's what we have seen in some people who have died and been faced down. So you appear to be saying there that the prone position in and of itself can make breathing more difficult.
Yes. That would be particularly worse with obese patients.
Returning to the manual, we can skip a paragraph and move on to the one that reads, the process of restraining often requires the upper body to be held down, sometimes by an officer's own body weight. This chain of events may trigger positional asphyxia. And you say in your statement to paragraph 46 that you agree it's true this series of events can trigger asphyxia. Now, again, we've heard from Inspector Young, and there are a number of statements before the chair to the effect that the training given to officers was broader than what we see here in black and white, and that officers were in fact trained not to apply weight to the upper torso, that the weight should be put through the shoulder if necessary. But we don't see a reference to that advice here, do we? Doctor, had you seen this manual before you were shown it at the time that you gave your statement to a member of the inquiry team?
I don't recall seeing the earlier manual.
We've heard that a PowerPoint was also used in training in 2015, and I wonder if we can look at that. It's PS 17208. And there are 3 slides on positional asphyxia. The first is slide 23. It says positional asphyxia is likely to occur when a subject is in a position that interferes with inhalation and/or exhalation and cannot escape that position. Death can occur rapidly and restraint can increase the risk. Do you have any comment to make on that content?
No, I agree with it, and especially that death can occur rapidly as well.
And do we note here that, by way of distinction between the PowerPoint and the manual, the PowerPoint refers to a position interfering with inhalation and/or exhalation, rather than the reference being to obstruction of the airway.
Yeah.
If we can move to the next slide, please. Risk factors. Body position which restricts or blocks the airway. Alcohol, drug intoxication, inability to escape the position. The subject is prone, pinned against a surface, slumped forward. Obesity, restraint, stress and respiratory muscle fatigue. Do you have any comment to make on those list factors?
No, I would agree with all those.
Okay. Is there anything, in your opinion, missing from that list?
I can't think of one.
Okay. We spoke earlier about chest impingement or application of pressure to the torso, but that doesn't seem to have been included in the list. And again, as we've already discussed, there's evidence before the chair that there is a relationship between the length of time that a person is in a position that restricts the airway or is prone and the risk of positional asphyxia, which doesn't appear to be mentioned. There's nothing there about the length of time. No. Can we move on to the next slide, please? Signs and symptoms: active to passive, loud to quiet, gurgling, gasping sounds, cyanosis, and verbals. Do you have any comment to make on the signs and symptoms that are listed?
Just that usually these signs are late on in the process, and probably will mean that cardiac arrest is imminent.
Doctor, are there earlier signs and symptoms that a layperson might pick up on?
Not really. Well, they may see someone panting, hyperventilating, but there's not really anything to say that person's got positional asphyxia. It's a very slow, insipid process.
I wonder if we can look briefly at the first aid materials from 2015. Let's look at spells firstly, although I think the content of the spells and the first aid at work is very similar. But the spells is PS 12313. And so here we are, Scottish Police Emergency Life Support. Can we go to page 15, please? Sorry, can we scroll down a little? It's page 15 of the PDF. It may not be page 15 of the manual. Is that page 15 of the PDF? I think I must have the wrong reference. I wonder then if we can look at the first aid manual instead. I think the content of the two is the same. And the reference for the first aid manual is PS 12384. I understand this is the first aid at work manual. If we can maybe look at the content of the first page. Do we have a date on it? It appears to relate to first aid at work, and it's July 2014. Thank you. Can we go to what is page 46 of the manual, but I think it's 50 on the PDF? And if we scroll down a little, please. A little bit more. The bottom bullet point there is, there we are, positional asphyxia. The death of persons in custody has been attributed to this condition. In otherwise healthy individuals, it can occur where an individual is held down or placed in a prone, face-down position. Although instances are comparatively rare, risks may be increased where the detainee is obese, drugged, or intoxicated. Would you have any comment to make on that first paragraph, Doctor?
No, I would agree with that.
Second paragraph reads, most recent medical opinion suggests that it is restraint and the exertion against such restraint that may result in death rather than the casualty's position. Some doctors put forward the view that the condition may exist exclusively in intoxicated and obese persons, particularly those persons with a beer belly. The term restraint-associated death may give a more accurate description of this condition. Do you have any comment to make on that paragraph?
I think that's overly simplistic of what the process is. It's the right to draw attention to the obese persons, but people that are not obese can suffer from this.
And in relation to the statement that most recent medical opinion suggests that it's the restraint and the exertion against such restraint that may result in death rather than the casualty's position, the inquiry has heard evidence about the risks of positional asphyxia, and I wonder if you have a view as to whether the comment there that we see in a first aid at work manual is an appropriate one?
I think it's an appropriate one. I'm not familiar with that particular research that has been quoted.
Sorry, did you say appropriate or inappropriate?
Appropriate.
You think it's appropriate?
Yeah.
The statement that recent medical opinion suggests it's restraint and the exertion against such restraint that may result in death rather than position.
No, I don't agree with it.
You don't agree with
No.
that? We may come back to that, Doctor, but for now we shall move on from that. This, I think, if we scroll down, we can confirm that this is the entire chapter on, yes, positional asphyxia. That's all that the First Aid at Work manual has in relation to positional asphyxia. So there doesn't appear to be anything there about risk factors or signs and symptoms or the management of the condition. I wonder if we can move on to the 2022 materials. Can we look at the current Officer or Operational Safety Manual, PS 18539? Module 4, Medical Implications and Mental Health. And if we can go to page 3 of the PDF, please. and look at what the current manual says about positional asphyxia. Positional asphyxia, also known as postural asphyxia, is a form of asphyxia that occurs when a subject's position prevents them from breathing adequately and may result in respiratory failure and death. And you make a comment in your statement, and again, we'll just keep this on the screen, but this is paragraph 66 of your statement, that the language is more user-friendly than the language used in the 2013 manual. Asphyxia is not simply someone being stopped from breathing completely. It may also occur because someone isn't able to breathe in sufficient air to meet their body's need of oxygen, something that may happen during a prolonged physical struggle. If we look at the second paragraph here, positional asphyxia can occur rapidly when the subject is placed in a position that impedes the ability to inhale and exhale breath. It most commonly occurs in persons intoxicated with alcohol or drugs, or to those with reduced levels of consciousness. Being placed in the prone position for an undue period of time, or pressure applied to the back or chest, have been found to be major causes of positional asphyxia in the past. And again, you say in your statement that you agree with that content, and there appears to be a clearer explanation of positional asphyxia here than there was in the 2013 manual. Is that correct?
Yes.
If we move on to the next page, please, where the risk factors are listed. Factors that make an individual more susceptible to positional asphyxia: age, obesity, alcohol and/or drugs, exhaustion, fatigue, respiratory illness, disability, including pre-existing conditions such as epilepsy and asthma, physical position, in car, van, footwell, slumped face down, and restraint. And you say in your statement at paragraph 69 that you can't think of anything of significance that's missing from the list.
No.
Signs and symptoms: difficulty breathing, gurgling or rasping sounds, subject verbalizes they cannot breathe, panic, swelling in the face and neck, expansion of veins in the neck, behavioural changes, inactive subject suddenly becomes passive or allowed subject becomes quiet, cyanosis, lips, nail, bed, gums are discoloured, a late sign and difficult to identify. And again, we'll leave this on the screen, but at paragraph 71 of your statement you say, I don't think it's appropriate for a layperson to be looking for these because clinically they are subtle signs, even for trained medical personnel to identify. And you mentioned that earlier in relation to the cyanosis.
The cyanosis, yes.
Okay. Would that apply to all of these different signs or just the cyanosis?
I would say the swelling in the neck, expansion of the veins in the neck. That would be difficult for lay people to take note of. The other changes, I would agree that they could be seen.
Can we move on to the next page of the manual, please? Restraint. If a subject is placed in the prone position during restraint, breathing can become more difficult due to the internal organs putting pressure onto the diaphragm. If the subject's arms are restrained to the rear, the pectoral muscles can be affected, and this can also restrict the ability to breathe. Would you have any comment in relation to that?
No, it seems that's accurate.
It's accurate. Okay. Moving on to the next paragraph. During the process of restraining a subject, the officer staff may be required to use body weight to restrain a subject. This additional pressure to the upper body, in addition to the police restraint techniques, may restrict the subject's ability to breathe and subsequently cause the subject to struggle harder in an attempt to breathe. This struggling could be misinterpreted as an act of violence directed towards the officer or staff, who as a natural response might apply additional pressure to the subject in an attempt to restrain them further. The officer or staff should be aware of this cycle of events and the possibility of causing positional asphyxia. And again, do you have any comment to make in relation to that?
No, other than it's very difficult for police or lay people, even for medical qualified people, to know whether someone's becoming hypoxic due to positional asphyxia, or whether they're just being aggressive and fighting.
And in relation to this cycle, as it's referred to at the bottom of that paragraph, I think you say in your inquiry statement that this is crucial information to make officers aware of.
Yes.
In your inquiry statement at paragraph 77, you say that you think this guidance is up to date and appropriate.
Yes.
Has any of the content been written by you?
Not in this, no.
Sorry?
No.
No. Before we look at the next document in the training materials, I'm conscious of the time, sir. I wonder if this is a convenient place to break.
Yes, well, we'll take a 15-minute break here. Ms Thompson.
Thank you. Can we go back to the first aid manual from 2015, please? That's PS 12384. At what is page 50 of the PDF. If we scroll down, please. Thank you. If we stop there. Doctor, we've looked at this already, and I invited your opinion on that second paragraph. And I think that I've caused confusion here, and we've possibly been at cross purposes, and I want to just try and resolve this. So if we look again at the first sentence in that second paragraph, most recent medical opinion suggests that it is restraint and the exertion against such restraint that may result in death, rather than the casualty's position. Now, the inquiry has heard quite extensive evidence during the cause of death hearing from a number of expert witnesses, including two pathologists, a Dr Shearer from Edinburgh and a Dr Nat Carey, who's a Home Office pathologist, to the effect that restraint and struggle against restraint can cause death. Their evidence, however, was that position is still an important factor and not one that should be left out of consideration. And I see you nodding your head.
Yes.
Would you agree with that?
I would, yes.
So to the extent that the way that this paragraph is worded might suggest to the reader that position is unimportant or irrelevant, I wonder whether it could perhaps have been phrased a little differently.
Yes, I agree with that.
You would agree. Thank you. There was one other matter I wanted to clarify with you. Before the break, you referred to positional asphyxia as a slow and insipid process, and I think that's on page 74 of the transcript. And again, we have heard evidence that a person who has suffered from positional asphyxia can collapse really quite suddenly and without any apparent warning. And I just wondered if you could perhaps explain what you mean by it being a slow and insipid process and how that might fit with evidence of sudden collapse.
I agree. I agree that it can be both slow or it can be, rapid. In the case of it being rapid, I think it would have to be a significant insult to the body to reduce the work of breathing. The slow aspect of it is where there's just gradual obstruction of the airways or gradual obstruction of the chest wall movements, and then that would be a slow mechanism for positional asphyxia to occur.
Thank you. We were going to go on to look at the 2022 operational safety training materials. Let's begin with the manual, PS 18539. So medical implications in mental health. If we scroll through, please, as far as page 3. Yeah, I did. Sorry, can you give me just a moment, please? I think I've lost my place in my own notes, Doctor. Bear with me just a second. Yes, it was the PowerPoint we were about to look at. Sorry, it was the PowerPoint we were about to look at, not the manual before the break. My apologies. So the current first aid PowerPoint is PS 18585. So we can see this is operational first aid, version 2. And if we can go to slide 31, please. Positional asphyxia can occur when a person is placed in a position that interferes with inhalation and/or exhalation, Risk factors include physical position and restraint, alcohol and or drugs, age, obesity, exhaustion, fatigue, respiratory illness and disability. And I think you say in your inquiry statement that that covers the key risk factors. Again, we don't see mention there of the prone position or the length of time that a person is in position or the application of body weight as risk factors. And we've yet to hear evidence about the way that officers are trained today. Moving on to the next slide, please. Signs and symptoms: body position, gurgling, gasping, behavioural changes, panic, verbalising that they cannot breathe. And in your statement, in relation to body position, you say it would be if the person's been restrained in the prone position or if they're curled up in a ball.
Yes.
Okay. Can you expand on that perhaps a little?
So if they were curled up in a ball, they're impairing their diaphragm's ability to ventilate the lungs, and you would remove them from the prone position to get the weight of the organs off the diaphragm and allow it to ventilate the chest again.
Otherwise, do you have any comment on the list of signs and symptoms in the PowerPoint?
No, I think that covers everything.
In relation to treatment, remove from prone ASAP, treat as a medical emergency, continue to monitor the casualty's condition, CPR if indicated. Again, do you have any comment there?
No, I would agree with that. It's been making people aware that CPR may be necessary in these cases.
Let's look now at the current probationer first aid manual, which is PS 18581. Unit 1, Lesson 7. We can see this is the probationer training programme. Unit 1, Lesson 7. And I think we're at page 35 of the PDF. Positional asphyxia. So you make the observation in your statement, Doctor, that this reflects in the material in the corresponding PowerPoint, but in greater detail. So let's move through this quickly. If we scroll down a little, please, so we can see more of the text on the left. Officer staff should be familiar with the dangers of positional asphyxia. Positional asphyxia can occur when a person is placed in a position that interferes with inhalation and or exhalation and cannot escape that position, usually when placed on their front. It is most commonly found in persons intoxicated with alcohol and or drugs, or with a reduced conscious level from head injury. Persons who have been sprayed with irritant spray are also at an increased risk. Death can occur rapidly as a consequence, and there have been cases where police officers have been found liable. Is there any comment that you would wish to make in relation to that?
No, I would agree with it.
I think we can move on then to look at training on ABD. And again, we'll begin, Doctor, by looking at the 2015 materials, and then we'll look at the up-to-date materials. So let's return to the 2013 Probationer's Manual, please, PS 10938. I've seen this document before. If we can go to what is page 24 of the manual, but page 30 of the PDF. If we can scroll down a little, please. Excited delirium, as it was known in 2015, I believe. What is excited delirium? This is when a subject exhibits violent behaviour in a bizarre and manic way. Excited delirium is a rare form of severe mania which may form part of the spectrum of manic depressive psychosis and chronic schizophrenia. So firstly, if we look at the language used here, excited delirium, we know that the condition is now known as ABD. The Can I invite your comment on the content of the statement, a rare form of severe mania which may form part of the spectrum of manic depressive psychosis and chronic schizophrenia?
So I would disagree with that and wouldn't use those terms. Aside from the excited delirium part, a rare form of severe mania, that's incorrect. Mania is one form, but it's not part of excited delirium. And then this part of the spectrum of manic depressive psychosis and chronic schizophrenia, the vast majority of cases are due to drugs rather than mental health.
The manual reads, it is characterised by constant, purposeless, often violent activity with incoherent or meaningless speech and hallucinations with paranoid delusions. And I think you comment in your statement that that is accurate.
Yes.
Subjects can be dangerous and may die of acute exhaustive mania. Hyperthermia, overheating and profuse sweating, even in cold weather, is often part of the condition. Can you comment on the content of that paragraph?
So I would remove they may die of acute exhaustive mania. I'll leave everything else in.
I think you explain in your statement that the medical profession don't use the phrase acute exhaustive mania.
No.
No. And why not? Does that mean anything to you, acute exhaustive mania?
It's a very, very old term, going back to probably early 1900s, when there wasn't a classification of illnesses back then, and it was used back then to diagnose like bipolar affective disorder.
If we scroll down a little bit, please. Thank you. Why is a subject in an excited delirium state of particular concern? Subjects suffering from excited delirium can die suddenly during or shortly after a violent struggle. This could occur whilst at hospital or in custody. Do you have any comment on the content there?
It's more likely to occur on site, on scene, rather than in hospital.
How is it caused? A combination of either drug intoxication, alcohol intoxication, or psychiatric illness. Cocaine is the most commonly associated drug with this condition. However, other drugs have the potential to induce excited delirium. Again, would you wish to offer any comment on
No.
that? Okay. If we scroll back up to the top of the page, right-hand column this time, please. How do officers identify a subject in a state of excited delirium? They will be abnormally strong, they will be abnormally tolerant to pain, incapacitant strays may not work, their skin may be hot, they may be hallucinating, hiding behind objects, running around or pulling their clothes off. They may suddenly become subdued or collapse after a bout of extreme violence. You would agree with all of that. I wonder if we can move briefly to your statement, please. We look at paragraph 55 of your statement. So you were shown this list. At 55 you say, I've been asked to comment on this. I agree with this list of symptoms. In terms of the individual showing abnormal strength, this is correct. I've seen 6 police officers trying to hold down a male with this condition and being thrown off by the individual who was not a muscular individual at all. Additionally, due to possible paranoia, they may feel the police or emergency support staff intend to harm them, and consequently they're in a fight for their life. You continue, police control techniques are the use of plain compliance techniques. The wrists are held with handcuffs or their arms are locked with a hammer lock on or other techniques. You stop moving because it's sore. If you stop moving, you will make it better for yourself. However, individuals suffering from ABD often have a reduced sensitivity to pain, so they keep fighting and fighting. And you explain that hot to the touch is a reference to hyperthermia, and you suggest that saying hot to the touch is more user-friendly, effectively, to the layperson than hyperthermia. If we can return to the manual, please. Sorry, the manual, please. It is, sorry, 10938. And I think we will be on page 30 or perhaps 31 of the manual. There we are. And where we are, on the right-hand column, if we could scroll down a little, please, so we have that heading. Actions to reduce the risk of death in restrained subject exhibiting excited delirium. The subject to be placed onto their side or into a kneeling, seated position as soon as possible. A subject who's been restrained and exhibits symptoms of excited delirium should be visually and verbally monitored closely. The subject should not be transported in the prone position if at all possible. Officers should be prepared to administer first aid if the subject's condition deteriorates. Would you like to comment on that content?
No, the only other thing I would put in is to say the definitive treatment is to bring to medical attention. But otherwise, everything else is fine.
So there are actions in terms of administering first aid and placing the person onto their side and monitoring them and so on, but there doesn't appear to be any mention there of de-escalation.
No.
Nor is there any mention of calling an ambulance.
No.
No. Although we see a little further down the page that any subject exhibiting symptoms of excited delirium should be treated as a medical emergency and assessed immediately at a hospital. Although the manual doesn't appear to offer any guidance as to how a person suffering from ABD should be conveyed to hospital. Would that be fair?
Yes.
I wonder if we can look again at the PowerPoint on excited delirium. That's PS 17208. It's slides 26 and 27, please. So there are two slides on excited delirium. A person exhibits violent behaviour in a bizarre and manic way, constant purposeless, often violent activity, meaningless speech and hallucinations with paranoid delusions, abnormal strength and pain tolerance, and CS may not work. And you note in your inquiry statement that the body feeling hot to the touch has not been included in that list. Would you have any other observations on that list of signs and symptoms?
No, I think that would be the most important one. I would want included.
If we move on to the next slide, please. Causes of excited delirium: drug and or alcohol intoxication, psychiatric illness or a combination of the two. Medical emergency: expect a sudden collapse, acute exhaustive mania can be fatal. Again, would you wish to offer any comment on the content here?
I would just want to say that under the causes, the vast majority is down to drugs rather than psychiatric illness. And the medical emergency bit, again, not use acute exhaustive mania. I would just use sudden death may occur.
And again, in your inquiry statement, and I'll just read from it if I may, so we're not chopping and changing documents, you say at paragraph 37 of your statement that the slides include symptoms, the fact it's an emergency, and the causes, but they don't give advice on how to handle the situation. I'm asked what advice I would expect to see. Back in 2015, the training would simply be to get the person to hospital based on the fact it was a medical emergency. Let's look now at the first aid materials. I won't ask you to look at the spells materials. So far as I can see, there's nothing about excited delirium in those materials. But if we look at the first aid at work manual, this is PS 12384. So let's just get our bearings here. Is this the first aid at work manual? First aid manual. And I'd like to go to page 47, which I think is 51 of the PDF. Excited delirium syndrome. A delirium is characterized by a severe disturbance in the level of consciousness and a change in mental status over a relatively short period of time. Signs: profuse sweating due to hyperthermia, reduced clarity of awareness in their environment, the ability to focus, sustain, or shift attention is impaired. The individual's attention wanders and is easily distracted by other stimuli. The individual is almost certainly disorientated and may not know what year it is, where they are, what they are doing, and the impact of their behaviour. Perceptual disturbances are common, and the person may hallucinate. Would you have any comment to make on the list of signs that are listed there?
No, that seems quite comprehensive.
Okay. If we scroll down a little, a delirium is the result of a serious and potentially life-threatening medical condition. Potential causes include infection, head trauma, fever, and adverse reactions to medication or overdose of illegal drugs such as cocaine and methamphetamines. Any person who is delirious requires prompt medical evaluation and treatment. The delirious person is likely to manifest an acute behavioural disturbance. These individuals can appear normal until they are questioned, challenged, or confronted. When confronted or frightened, these individuals can become oppositional, defiant, angry, paranoid, and aggressive. Further confrontation, threats, and use of force will almost certainly result in further aggression and even violence. Attempting to restrain and control these individuals can be difficult because they frequently possess unusual strength, pain insensitivity, and instinctive resistance to any use of force. As many as 5 to 8 people may be required to restrain one delirious adult. Would you have any comment to make on the content there?
No, I would agree with it.
Okay. Let's scroll down. There are some Police Complaints Authority recommendations. Recommend the following training for police officers to help them differentiate between intoxication and excited delirium syndrome. Learn how to recognise the signs of delirium or the initial symptoms. Obtain immediate medical consultation and attention for any person who may suffer from a delirium. Do not excite, confront, or agitate individuals who are delirious. Contain rather than restrain when the individual is not dangerous to self or others. Avoid the use of force unless the individual is dangerous to self or others. Use the lowest level of force necessary as well as a method of restraint that will not cause asphyxiation. And be cautious and aware of potential side effects of medication. Do you have any comment to make on the advice given by the Police Complaints Authority?
No, I'm glad that they draw attention to the fact that you should contain rather than restrain. That's particularly important.
And if we can go to the top of that little passage of advice, please, where they recommend this training to help officers differentiate between intoxication and excited delirium. In your statement, paragraph 104, you question whether it's appropriate for a police officer to try and identify a delirious state or its cause because a medical practitioner may struggle to identify a delirious state.
Yeah.
And could it in fact be difficult to differentiate between intoxication and delirium?
Yeah, I don't think it would be expected of a police officer to recognise delirium because medical professionals can sometimes fail to recognise it as well, and the police officers are not trained.
So is their training, as you understand it, more about identifying red flags?
Yes.
And seeking medical help?
Yes.
Again, we see a reference to obtaining immediate medical consultation and attention, but there doesn't appear to be any guidance on how that looks in practice in terms of whether you convey a person to hospital or call an ambulance.
No, I would agree.
I wonder if we can move on to the current materials. The Operational Safety Training Manual from 2022 is PES 18539. And page 6, I think, relates to ABD. Acute behavioural disturbance, so we see immediately a change in the language being used there from ED to ABD. Just as abnormal brain function can be associated with a stupor or loss of consciousness, it can also cause confusion or agitation. A severe brain agitation is sometimes known as excited delirium or agitated delirium, or more commonly to the police as acute behavioural disturbance. ABD is described by the Royal College of Emergency Medicine as the sudden onset of aggressive and violent behaviour. It has been described as when a subject exhibits violent behaviour in a bizarre and manic way, rather than simply being violent. Would you have any comment to make on the content of those paragraphs?
No, I'm pleased that they are referring it to acute behavioural disturbance now. And I agree with my own College of Emergency Medicine.
If we go a little bit further, ABD is a rare form of severe mania and sometimes considered part of the spectrum of manic depressive psychosis and chronic schizophrenia. However, many of the signs indicating ABD are common to anyone behaving violently. I think we can note this is quite similar wording to the 2013 manual, and you considered that the terminology was out of date,
Yes.
dated back to the 1900s. Would you have the same comment to make here?
Yeah, I wouldn't refer to ABD as a severe mania or spectrum of manic depressive psychosis.
Possible causes are listed. We can go through these very quickly. Drug intoxication, and there's a reference now to new psychoactive substances, legal highs, alcohol intoxication, drug and or alcohol withdrawal state, psychiatric illness, acute brain injury, acute illnesses resulting in brain inflammation, metabolic problems or limited supply of oxygen to the brain, and low blood sugar. I think in your inquiry statement you say this list is a comprehensive list of the possible causes
Yes.
of ABD. And you explain too that some of these causes are ones that you can screen for in A&E.
Yes.
Was that a reference to the blood gases looking for blood sugar?
Yes, that's right.
And you told us about that before lunch. Okay, finally the signs and symptoms. Sorry, I think we'll have to scroll up again, and it's on the right-hand column of the same page. Thank you. Subjects suffering from ABD may present the following signs and symptoms: constant, near constant activity, unexpected physical strength, significantly diminished sense of pain, non-responsive to the presence of authority figures, unable to follow commands, rapid breathing or panting, do not fatigue, apparent ineffectiveness of irritant spray, violent, bizarre or aggressive behaviour, shouting or panicking, sweating fever, hot to the touch, removing clothes, impaired thinking, disorientation or feelings of paranoia, attracted to or attempt to destroy glass and reflective objects. They may be hallucinating, hiding objects, running around. Sudden tranquility after a period of frenzied activity. Sorry, if we can scroll down a little bit, please. Or vice versa. Do you have any comment on that list?
No, it's quite an extensive list.
Do we see near the top of that list, non-responsive to the presence of authority figures, unable to follow commands?
Yes.
And I don't think that was in the 2015 materials. That
No.
looks to be a new entry. Moving on to page 7. Management of persons with ABD. It is recognised that controlling a subject suffering from ABD will always be very difficult. Officers' staff may have to place them face down on the ground in order to handcuff them safely. Must remember the risks of positional asphyxia affecting a subject who has a brain agitation are far greater than that of a normal violent person. Subjects may be very difficult to control and can continue to struggle beyond the point of exhaustion, making them very difficult to stop whether or not handcuffs are applied. Once handcuffs, officers' staff should not try to restrain a subject face down. Subjects should be placed onto their side or into the sitting, kneeling or standing position as soon as it is safe to do so. They may continue to kick out, and the officer staff may have to consider application of fast straps. Such bizarre, exhaustive and persistent violent behaviour is a classic indication of ABD. The subject must be monitored carefully as they could collapse or suffer cardiac arrest at any time. Officers' staff must treat subjects suffering from ABD as a medical emergency. They must be treated in hospital as a matter of urgency, even if they suddenly calm down before they get there. If officers or staff suspect they may be dealing with an ABD subject, then the subject must be checked out at hospital as soon as possible. Officers will not be criticised for taking action. Subjects suffering from ABD can collapse very suddenly, and attempts to resuscitate are often unsuccessful. Do you have any comment to make on the content here?
No, I agree with it all, and also as well, it's important to emphasise that officers will not be criticised for taking someone to hospital for suspect ABD.
Earlier in your evidence, you said that you don't perhaps get the heads up that an ABD patient is being brought to your emergency department as often as you would like.
Mm-hmm.
And I wonder whether it would be helpful to include in the guidance a recommendation that if a person is being conveyed to hospital, whether by police or in an ambulance accompanied by police, they might call ahead.
Mm-hmm. That would be welcome.
If we can scroll up again, please, and look at the right-hand column, operational guidance. All subjects who struggle, whether handcuffed or not, risk exhaustion. This increases the chances of sudden death from cardiac arrest, positional asphyxia, or other medical issues that can occur anywhere from the locus to the cells. Officers' staff need to be aware of this and ready to deal with any medical issues as an emergency should the need arise. If required, subjects may need to be taken to hospital rather than police custody. Would you take issue with anything in that paragraph, Doctor?
No.
Officers' staff must consider the following actions: recognise the situation as a medical emergency if possible, alert the hospital staff before arrival to allow appropriate preparation. So that's my oversight. I see, in fact, that recommendation has already been incorporated into the guidance. Attempts at verbal de-escalation are often unsuccessful. If safe to do so, subjects should be permitted comparative freedom of movement within a given area. What would be regarded as a contained situation, and consideration must, if possible, be given to alternative options to restraining a subject who is suspected to be suffering from ABD while still affording an appropriate measure of protection for the subject, officer, staff and the public. So far as alerting hospital staff is concerned, you explained earlier in your evidence why that's helpful from a medical perspective. I wonder whether that was a recommendation that you had made at any point through the work that you've done with Inspector Young and your clinical governance work, or if it's made its way into the recommendations through another route.
I wonder, because I was saying that back in 2015 to HMP custody patients as well as police, to alert us if they bring somebody in who's potentially violent.
We see it noted at the second bullet point, attempts at verbal de-escalation are often unsuccessful, and you make the observation in your inquiry statement at paragraph 88 that this could be better worded, as it could be read to suggest that verbal de-escalation is often unsuccessful and so not worth attempting. However, I agree that attempts at de-escalation are often unsuccessful. But the evidence that you gave this morning is that your practice, and indeed the Royal College guidelines, are that de-escalation should always be attempted.
Yes.
If we move through the document, please, I think we have one more page to look at. Restraining subjects with acute behavioural disturbance. And the guidance states that the aim of any physical restraint is to minimise the ability of the subject to move and injure themselves or others, at the same time to ensure the subject has a clear airway and circulation is not obstructed. Officer staff may be required to restrain subjects at the scene to protect themselves from further injury and await medical assistance, or to protect the officer or staff and the public. In either case, the following guidance should be followed. Persons who appear to have this condition should be restrained only in an emergency. Restraint should be the minimum necessary and for the shortest practical duration to facilitate transfer to definitive care, and sufficient staff officers should be present to ensure safe restraint. The lead officer or staff should explain to the subject what is happening in a calm fashion. Sorry, if we can scroll down a wee bit, please. Immediately after the subject comes under physical control, they should be placed onto their side or into a sitting, kneeling or standing position. Prolonged restraint in the prone position must be avoided. Officer staff should observe the subject's condition continually while being restrained, as death can occur suddenly and develop beyond the point of viable resuscitation within seconds rather than minutes. Whenever possible during restraint, a safety officer should be identified. Their responsibility will be to monitor the health and safety of the subject during restraint. And in relation to that advice, you say in your inquiry statement, paragraph 92, I think that section is actually my wording. And you go on to say that you recommended the inclusion of a safety officer.
Yes, that's right.
Why did you do that?
We've learned from our own medical training that if you're dealing with a very sick person, you can't do tasks and effectively monitor the patient at the same time. So we have one person who stands back, and they're the overall coordinator, and their job is to watch the individual who's receiving treatment.
And finally, if we go back to the top of the right-hand column, please. This is guidance in the event that a person loses consciousness. Call for immediate emergency medical assistance and transfer to hospital. Transfer to hospital should, where possible, be carried out by ambulance. If this is not possible, the subject should be transported by police vehicle. Where possible, avoid placing the subject in the cell area of the vehicle. Remove all methods of restraint if safe to do so. Prior to arriving at hospital, contact should be made with the receiving A&E unit and full details of the subject's condition communicated. Place the subject in a position that does not impede their breathing. Commence CPR if required. Notify a supervisory officer if one is not present. And a full record of perception of the subject's condition and their actions should be marked up in a notebook or custody record. Would you have any comment to make on the information in that section?
No, happy with that, thank you.
And the reference to removing all methods of restraint if safe to do so, I don't think that featured in earlier materials.
No. The police are often reluctant to remove restraint when they've got control over an individual, but it's important to emphasise that it is for the safety of the individual.
Finally, let's look at the current first aid materials, please. If we can look at PS 18581, which is the operational first aid training programme, and I think it's page 39 of the PDF. So if we scroll down, please, so we have a little more of the text. ABD is the accepted terminology adopted by the UK Police Force's Ambulance Service and Faculty of Forensic and Legal Medicine. Comprises a triad of acute delirium, severe agitation or aggression, and autonomic disturbance, usually associated with drug use or substance withdrawal, but can be caused by other medical conditions. 10 to 20% of cases are caused by pure psychiatric disturbance, and death occurs in around 10% of presentations. If we can scroll down a little bit, ABD is characterised by 3 factors: delirium, agitation or aggression, and abnormal physiology. Would you have any comment on the content of this page of the operational first aid manual, Doctor?
I'm happy with that.
Happy with that. If we scroll a little bit further on, please. Persons suffering from ABD can die suddenly or shortly after a violent struggle. No warning signs to indicate when a person may suffer cardiac arrest. A number of possible causes. They include drug intoxication, cocaine being the best known, alcohol intoxication, drug or alcohol withdrawal, psychiatric illness, brain injury, acute illnesses resulting in brain inflammation, metabolic problems, or limited supply of oxygen to the brain, and low blood sugar. Any comment on that list?
No, that's fairly
That's comprehensive.
Yeah.
Let's look at the signs and symptoms. constant, near constant activity, abnormal strength, abnormal tolerance to pain, irritant sprays may not work, hallucinations, hiding objects, running around, pulling clothes off, non-responsive to presence of authority figures, unable to follow commands, rapid breathing or panting, resistance to fatigue, violent shouting or panicking, sweating perhaps profusely, skin may be hot to the touch, attracted to glass and reflective objects, may suddenly become subdued or even collapse after a bout of extreme violence. Do you have any comment on the list of signs and symptoms?
No, happy with that as well.
If we can move through the manual, please. Officers, staff must treat persons suffering from ABD as a medical emergency. Then there's a section on management, which recognises controlling a person will always be difficult. May have to place the person face down on the ground in order to restrain and handcuff them safely. The risks of positional asphyxia affecting a person presenting symptoms of ABD are far greater than for a normal violent person. Sudden death as a result of cardiovascular collapse and extreme abnormal physiology is more likely. Persons experiencing ABD must be examined at hospital even if they suddenly calm down. Would you have any comment on the content of that paragraph, Doctor?
Again, it doesn't say how to get them to the hospital, but I think we are understanding of that.
If we scroll down a little bit further. Once handcuffed, officers, staff should not try to hold the person face down. Immediately after the person comes under physical control, they should be placed onto their side. Prolonged restraint in the prone position must be avoided. Call for emergency medical assistance and transfer to hospital. And as you said a moment ago, there's nothing there about how the person should be conveyed to hospital. Observe the person's condition continually while being restrained, as cardiac arrest can occur suddenly and develop beyond the point of viable resuscitation within seconds rather than minutes. If they become unconscious and stop breathing, begin CPR. Would you have any comment to make on this list of management points?
No, I'm quite happy with those things.
Okay. There doesn't appear to be anything in that list about de-escalation.
Again, I think we probably should put it in to say try, but the success rate is quite low.
Okay. And there doesn't seem to be a carryover of the advice to contain rather than restrain that we saw in the operational safety training manual. Thank you for your assistance in going through those materials. We can put those to one side now. There's one final matter that I would like to ask you about. I said that we might return to your role as a special constable. And your most recent refresher for operational safety training was almost a year ago now. But can you recall whether it covered positional asphyxia or ABD?
Yes, both of those are featured in the PowerPoint presentation.
They feature in the PowerPoint. Do they feature in the classroom element, the face-to-face training that follows?
I think the trainers may make passing comment to them about ABD, but for positional asphyxia, they warn when you're doing the handcuffing or doing the leg restraints that you mustn't lay them they're prone for too long a period.
Thank you. Can you bear with me just a second, please? Thank you. Doctor, one final thing. As we went through the materials, we identified areas where there were perhaps differences between the first aid materials and the operational safety training materials at the same point in time. And we may hear evidence next week that there is going to be a review in the near future. And I wonder whether you would see any advantage in there being standardisation across the board so that the same information is being conveyed in operational safety training and in operational first aid, and a consistency in the message that's being given.
Yeah, they should be aligned, yes.
Thank you. That concludes my examination. I have no further questions.
Are there any Rule 9 applications? Dr Stevenson, thank you very much for coming to give evidence to the inquiry. I'm very grateful for your time taken to do that. We're about to adjourn for the day, and you'll be free to go then.
Thank you.
Inquiry will adjourn.